You're up and running, all right. Good afternoon, this is the continued COA hearing for the Norwalk Hospital Association document number 25-32808-CON. The Norwalk Hospital Association, the applicant in this matter, seek a certificate of need for the establishment of cardiac services pursuant to Connecticut General Statutes, section 1980-638, small a, 9. Specifically, the applicant seeks approval to extend current cardiovascular services to include elective percutaneous coronary intervention services without on-site cardiac surgery. We are going to go and move to the public portion of this hearing and come back to OHS questions after the public portion has concluded. For those of you who are just joining us, the Center for the Public Comment has been all day on Zoom and in the comment section, and also in the room as well, just to give everybody a sense of how long we can expect the public portion of today's hearing to run. I typically allow commenters to speak for 3 minutes, with elected and appointed officials being granted flexibility. In order to, the order of comment will likely be as follows, although some exceptions may be made. 1, elected and appointed officials and representatives. 2, the applicant's clinical professionals and executives. And 3, other clinical professionals and executives. 4, other members of the public. We will call the names of those who have signed up to speak in the order in which they were registered. Additionally, we strongly encourage you and anyone listening to submit any further written comments to OHS by email or to mail no later than 1 week, 7 calendar days from today. The email address is concomment@ct.gov. And that is CONDOMMENT@ct.gov. I'd ask you to please try the best of your abilities to limit duplication of content. Our contact information is on our website and in the public information sheet, which is provided in the top of the room, I believe. All right. Sorry. Thank you for taking your time to be here today and for your cooperation. We are now ready to hear statements from the public. Dan from our office will read off. Do you have a list?
I don't.
Yeah. Boyd, you have that. Boyd will read off one name at a time. Please be prepared to speak when it is your turn. Anyone speaking remotely, I would remind you to turn your video and microphone on.
We'll start with Representative Kadeem Roberts. Representative Harry Rilling is virtually or here?
On his way.
Okay, we'll join. Karen Gottlieb is virtual. And Jeffrey Cuban is online. And Representative Donnie Johnson is also virtual. All right, Representative Roberts.
Hang on just a moment. I'm trying to. Everything is in reverse, so it's really. Okay, here we go. Whenever you're ready, sir.
Good afternoon, OHS staff, and to all those attending today. I'm State Representative Kadeem Roberts. I appreciate the opportunity to comment on the application process before you all today of Norwalk Hospital to expand PCI services from my community. Born and bred in the city you guys are living in now. Spent 34 years of my life born and bred and raised and born in that hospital that you guys are here in this application process. Simply around the corner, go down the hospital hill, turn to the right. It's probably one of the poorest housing projects in the state of Connecticut. Born and raised there, still have an aunt that lives there. My community, as you guys can see, is Black and brown. When we talk about the leading cause of heart disease, we know what type of people lead that cause of heart disease. So today, I just want to tell you guys, for me, and a story that's truly to me, EJ's heart, a guy by the name of Trey Gilmore, is my hero, mentor, but most importantly, he's someone that was a security guard in high school. His son EJ died from a heart attack at 5 years old, right here in Norwalk. Services wasn't given to him, wasn't able to be given to him. Now, currently, you know, the price of services over a life is what Gilmore still has to go through for the rest of his life. And My biggest part is he has now started a nonprofit, is now getting back to his known community about health and wealth, and just, trying to stay focused. I say this to say, you guys, I understand that heart disease remains the leading cause of death. And that ease of access to early intervention is key in most, positive outcome. I know that OHS's mission is to ensure access to high quality and lower cost of care. I've heard there are new standards for this kind of care that I hope is given serious consideration. I gotta be honest with you guys, I'm a little confused and also concerned that this life-saving care has not been approved with previous applications. We have been working hard to make health more equitable, and it begs the question when thinking about other communities where the procedure is allowed. Why life in Stanford, New Haven, Hartford is more important than Norwalk. So for me, today, I just want to be blunt and honest with you guys. Let's get this done for the Norwalk residents. Because this is kind of like marginalization of my community and where I come from. It's the sixth largest city, fastest growing city in the state. It's really, really traumatizing to hear this process and this application situation going on today. So I truly just, I'm honored to speak to you guys today. The tables have turned, which is crazy, but I truly appreciate the opportunity. And like I said, just let's get this done for, my hospital that I truly dare love and represent on a regular basis. Family members still work in the hospital. If you gotta go and this is my city, so it's true to me. I sometimes don't sleep at night when I fight for this. So thank you so much.
Thank you, Representative. I saw Representative Johnson on the screen for theirs. You can go ahead. I think, Dan, are you able to show the representative on your screen?
Yes. There you
All right, turn the floor over to you, Representative.
Thank you very much. Appreciate this, and good afternoon, everyone. I join with my colleague in the Norwalk delegation, Representative Roberts.
We are not able to hear you. I think that is on our end. Just one moment.
Mine is the one controlling the Zoom.
I assume it's the audio is for the app. Let me, we're gonna have you talk through my computer.
Okay, can you hear me?
Yes.
Oh, fantastic. I'll speak up then. A good evening or afternoon, everyone. I join with my colleague, Representative Kadeem Roberts from the Norwalk delegation today to echo his encouragement for this CON to be expanded to PCI services. I represent the 143rd district, which encompasses parts of Norwalk and Westport. And I refer to my letter to you all and Commissioner Gifford, Dr. Gifford, January 7th of this year, just for the need for this for improving the health of our residents in Norwalk, especially given that Norwalk Hospital is a regional health hub for other communities in the Fairfield County area. I can tell you that many of my constituents who don't live in Norwalk, but oftentimes go to Norwalk Hospital for their health services, do not opt to go to Stanford because of potentially the concern about travel times. And I know that this procedure will play a life-saving role in early prevention and early detection of one of the most, some of the most important things we can do, regardless of your socioeconomic status, whether you're from Westport or Norwalk. We know that heart disease is, and you all obviously know how this is important for women in particular in our community to have this access to this care. I join in the delegation because the Norwalk Hospital is one of the economic drivers in Norwalk, as you know, and so being able to expand this access to care, making sure that the increased financial burden on the patient and the healthcare system is removed by making sure the certificate of need application for PCI services is approved, I think will really improve our folks' access to this care. And we'll also make sure that folks don't have to travel 40 minutes to get this care. Many of the children in our community depend upon this. We're seeing a lot of uncompensated care in our emergency rooms, and we know that that's a financial burden on our system as well. That only emergency care is offered for this condition, I think, is something we can improve upon, and I really encourage everyone to review our testimony in support of this. We would like Norwalk Hospital to be as strong and able as it can be to provide these health services for our region, not just our city, and those that depend upon it, and partner with you to make sure that we can improve this care on this really important procedure for cardiac health for everybody in the community. As Rep. Roberts said, we know the nurses, we know that the folks working in this hospital care deeply about their patients, and for them to be able to offer this elective care is just one more step in this direction. I'm happy to answer any questions related to my testimony. I appreciate the opportunity to be able to speak with you remotely today. Thank you.
Thank you, Representative. Mayor? There's my comment.
Good afternoon, thank you. You know, I'm here on behalf of the city of Norwalk, 93,000 residents and counting. And it's critically important. The mayor's job is to keep his or her city as safe as possible and to make sure that they have adequate health care. Now, as you know, Norwalk is a very diverse city. And oftentimes, these types of issues affect the minority people or people that don't have equitable access to high quality health care. It can impact families and the challenges that our underserved and minority communities have in receiving needed care. Heart disease, hypertension, and other cardiac disorders disproportionately impact minority communities, yet members of these communities face the most barriers to accessing cardiac care locally. Moreover, this should be a great addition to the Norwalk Hospital and their partnership with Northwell, which has taken them to another level. To better serve the people of Norwalk and beyond, providing the services needed at one location, and that certainly would be outstanding. So I would urge the approval of this important application to reduce those barriers and to expand access to the full continuum of cardiac care at Norwalk Hospital. We rely on the hospital to take care of all members of our community, regardless of class, race, or ability to pay. And we need the Norwalk Hospital to be strong and able to provide the treatment our families need. Just to give you an example, my cardiologist, Dr. Yetka, great, I have so much confidence in this guy, determined that I needed a stent. And it was said, you know, maybe we could go up tomorrow morning. And then he checked it again. He goes, oh, no, we have to go now. We had to go to Danbury. And that ride to Danbury was kind of frightening to me, because obviously I didn't know how bad it was or what was going on. But we got there and we had it done, but still that ride to Danbury was not something that was very pleasant. And you know, my parents have had great confidence in Norwalk Hospital. I was born at Norwalk Hospital, so I know what they can provide. I know that they're a world-class organization. The people, the staff are absolutely amazing. And to be able to provide this upgraded cardiac care would certainly be a benefit to the city of Norwalk. And as I said, we have 93,000 residents and we're growing. And as Representative Roberts said, we're the 6th largest city in the state of Connecticut. And I think it's about time that we're able to provide this service for our community, for our people right here in the city. And I urge you to approve this application. Thank you.
Thank you, Mr. Mayor. Karen Gottlieb? All right, we have Jeffrey Cuban.
Thank you very much. Can you hear me?
All right, let me unmute my computer and then you can proceed with your testimony.
Thank you very much. Can you hear me now?
Yes.
Great, thank you. My name is Dr. Jeffrey Kuvin, Kuvin. I'm the chair of cardiology for Northwell Health, and I'm also a past member of the American College of Cardiology Board of Trustees. This is the college that sets all of the standards of care for our community hospitals and our academic cath labs in this country. Northwell is, as you know, by far the largest provider of cardiovascular care in the region, and we are thrilled to incorporate Nuvance into our system. Northwell presently operates 39 catheterization laboratories in 16 locations. We perform over 13,000 PCIs annually. We consistently rank at the very top across the nation for quality, including the highest marks from state departments of health, U.S. News World Report, the Society for Thoracic Surgery, and the American College of Cardiology, amongst many others. As you've heard, at the present time, Norwalk Hospital has a very highly functioning cardiac catheterization laboratory, but it only serves our sickest of the sickest patients who present with STEMIs. Semi-elective and elective PCIs are not presently part of the hospital's CON, and I'm here to tell you that that is not standard of care. Northwell, like much of the United States, has embraced the concept of PCI in the community hospitals, given the overwhelming safety data and the long-term experience that we have across the country. We have a number of examples of highly functioning cath labs such as this across our system at Northwell. You heard from Dr. Singh about Northern Westchester Hospital earlier today. All of these perform elective, semi-acute, and acute PCI with great success, providing outstanding patient outcomes to our community, and many of these are without surgical backup. There is no reason to believe that Norwalk Hospital could not follow a similar path. The addition of elective and semi-acute PCI cases to Norwalk can be safely performed and will importantly enhance the cardiovascular care and the continuity of care for this local community. You've heard that numerous times this morning. Certainly, there's always a role for appropriate case selection, and there are well-established guidelines set by the ACC and others that help our clinicians make these decisions. In addition, as in the case of all Northwell facilities, a well-thought-out plan for acute transfers to a tertiary care facility with cardiac surgery is important should patients need seamless handoff to higher levels of care. Finally, you've heard a lot about patient experience and continuity of care, and having a fully functional cath lab at Norwalk is critical to provide the standard of care we owe to our patients. At Northwell, we strongly believe that Norwalk Hospital should be granted a full CON, inclusive of elective and semi-elective PCI. It's critical for this community to have access to these services, and it's the right next step for this hospital and community. I personally will ensure that Norwalk Hospital is fully incorporated into Northwell's Cardiovascular Institute's quality and standards oversight. Having a fully functional cardiac cath lab at Norwalk Hospital will elevate the care, save lives, and will be a superb addition to Connecticut's focus on patient-centered care. This should be a discussion not about business or economics, but rather a discussion about what is right for Norwalk, its community, and how we can provide the best standard of care. Thank you very much.
Thank you for your comment.
Okay, the last person who was presenting to us is now available online. I will give one last chance for people in the room if you would like to make comments at this time. All right. With that, we are going to head back into the technical portion of today's hearing, which is questions by OHS. I'm going to ask before we start that, Attorney Jensen and Attorney DeLacio are both of your witnesses, both of your witnesses up here. We know that one of yours did leave as they had to get back to questions.
My understanding is that he's, was going to try to join by Zoom if there's a specific question. Ben Jensen, the applicant. My understanding is that Dr. Singh was planning to join by Zoom in case there were specific questions.
Our witnesses are still present in the room. We can bring them down. We were trying to be conscious of space while the public comment was going on.
I feel that we're going to go in order of intervener questions first and then, applicant questions first, then intervener. So we can take a pause, bring us back down when it's time for your.
That's fine. That works for us. Thank you.
Attorney Johnson, I'm gonna start with high level or without level, just to give the public some understanding. There have been quite a few different types of PCI mentioned today. Maybe we can start with, for the knowledge of the general public, what is PCI? What are the different types of PCI?
Thank you, Hearing Officer Novi. I think Dr. Warshawski could address.
Hi, thank you for your question. So PCI stands for percutaneous coronary intervention. And it used to be called something like angioplasty or balloon inflation in the artery. Now, we've developed other ways of doing it that make it safer, including the addition of coronary stents, which really have helped to make this procedure very, very safe. And that means that the arteries that are running on the surface of the heart provide blood flow to the muscle of the heart. And when one of those arteries becomes blocked, you suffer chest pain or a heart attack or both. And that's obviously a life-threatening situation. There are patients who develop a blockage more slowly, and they have what we call a more stable syndrome. Those are patients who are usually in the community, they're walking around, and they start having chest pain when they reach a certain activity level. So when we talk about the spectrum of these patients, it goes from the ones who are in the community, walking around and having a stable syndrome of chest pain with a certain level of activity, all the way to those who are having a full-blown, full-thickness heart attack, which we call a STEMI, that those patients have no blood flow to the heart or extremely little to that area of the heart that that artery is supplying. And then there are patients in between who have an artery that may be opening and closing or have a very, very severe blockage that's impeding the blood flow but not completely cutting it off. Percutaneous coronary intervention is a procedure, again, where we go in, we put a wire across the blockage, we open it up, and then usually put a stent in to treat that blockage. So the patient who's coming in with a full-blown heart attack, the STEMI, is an emergent procedure that's done right away. They're taken immediately to the cath lab. That's currently what Norwalk Hospital is doing now. And you can imagine those patients, they come in, they're often pretty sick and pretty high risk. Then you have patients, again, in that intermediate group who have what we call an acute coronary syndrome. It's life-threatening, but it's not as an immediate emergency as the STEMI patients because there is a little bit of blood flow getting across. Those patients can certainly progress to a heart attack. Sometimes they come in with a small heart attack. They can have life-threatening cardiac arrhythmias, electrical disruptions of the heart. So when you put those patients on an ambulance to be transferred out of the hospital, there is a risk to them that something untoward is going to happen in the ambulance. So those patients, and by the way, the American College of Cardiology in their guidelines suggest that those patients, although not emergent patients, are pretty urgent patients and recommend a percutaneous coronary intervention within 12 hours if possible. Those patients were sort of brushed over, I think, in the intervener's testimony by calling them elective. They're really not elective, although granting us elective ability to do that will cover those patients. So, those patients, again, very, high-risk population, high risk of proceeding to death, full-blown heart attack, those patients should be intervened on if possible within 12 hours. We're talking about transferring those patients out of the hospital to be done in another hospital when Norwalk Hospital is already doing the even sicker patients. So then we have the patients, again, I'll just get to the last category, and they're all, you know, the two out of those three classes of patients, if you will, are covered by the term elective. And the third group that I mentioned are the outpatients who are more stable. And yes, there is data to show that medical therapy is as good as percutaneous coronary intervention in terms of keeping people from dying, right? But it's not just about dying. It's about quality of life. And, you know, it always, you know, puzzles me why we can talk about a hip replacement, which doesn't prolong life, but is paid for and done for patients who have a poor quality of life because they're in chronic pain and they can't walk far. But in patients who are outpatients and can't walk 20 feet because they get chest pain, we know that a stent is a better treatment for treating angina, that stable chest pain, than the medical therapy. So yes, there are some patients that can do just as well in terms of pain management with medical therapy, but there are patients who don't respond as well. And those patients do benefit from percutaneous coronary intervention. So I hope that answers the question in terms of what percutaneous coronary intervention is and the different classes of patients.
I have a follow-up to that. Said that the group that's not an immediate emergency but can progress and they're going to get transferred, you suggest PCI within 12 hours. Is that standard or?
It's a recommendation from the American College of Cardiology.
On the same topic, what are the differences between inpatient and outpatient PCI?
So it used to be that all PCI was considered an inpatient procedure. Again, because of the safety of this procedure in those patients who are coming in for stable coronary syndromes that are out in the community, the vast majority of those patients are outpatient procedures. There are some patients who come in with chest discomfort, and it's not really clear what's causing the chest discomfort. Is it an acute coronary syndrome or is it musculoskeletal pain? Sometimes those patients are admitted to observation, and if it's deemed after some observation that it's not a heart problem, then they're discharged and they're essentially never admitted to the hospital as inpatients. They're observation. But if those patients do have a suspicion, they're typically converted to inpatient. Any patient that is presenting to the emergency room where it's pretty clear that there's an issue there, they're admitted to the hospital. They're going to be an inpatient. So all of these patients that we're talking about needing to be transferred are inpatients. And again, I think you've heard some testimony about how that increases the cost of their care. The outpatients, again, if they're stable in the community, they have an abdominal stress test, it's decided that they need this procedure because they have pain that is not responsive to the medical therapy, then they would come in electively as an outpatient, they'd get their procedure, and potentially a fair amount of the time sent home that same day. And that would be what we term an outpatient procedure.
Can you can you walk me through a patient getting an outpatient elective PCI? Like what that would look like?
Sure. So, an outpatient, they go see Dr. Lomnitz in the office. He's been managing them for primary prevention. They start feeling some chest discomfort. How long have you had it? Couple months. Every time I walk up a hill, I get it. When I walk my dog, I get it. Dr. Lomnitz may or may not decide to do a stress test or another non-invasive procedure. The stress test is positive. Dr. Lomnitz feels that they need an angiogram to see what's going on. So the patient gets admitted. I shouldn't say admitted. The patient gets referred to Dr. Yekta. Dr. Yekta does an angiogram, and it shows a blockage. If Dr. Yekta does the angiogram at Norwalk Hospital, we're done right there. The patient will likely get sent home. And if they're willing to travel to another hospital to get their percutaneous coronary intervention, should it be deemed necessary, then they'll go to another hospital to get it. If this CON gets approved, that same patient, after getting referred to Dr. Yekta and getting their angiogram at Norwalk Hospital, will be able to then proceed in the same sitting, the same procedure, to a stent and go home. And it's done. And they don't have to worry about it.
Okay. Why might somebody need a emergency versus an elective?
So again, an emergency is a patient that's not that stable outpatient that we just spoke about, but one who comes into the emergency room usually and is having what we call an acute coronary syndrome. That's an unstable plaque in the artery that is getting clot on it and is severely blocking or completely blocking the artery. And that is either an emergency or an urgent situation. The emergency we spoke about is the STEMI, where there's complete blockage, there's ongoing pain, and there's ongoing damage to the heart muscle. Those patients are sick. Those patients are the ones who currently can be done at Norwalk Hospital. The intermediate patients that we've been talking about, that middle group of patients, which are still called elective by the state, are still, as you heard earlier, are urgent patients. And those patients need to be intervened on. They need to have this procedure or other type of, whether it be, other type of revascularization, preferably in that same hospitalization in a short amount of time. And again, the recommendation for those patients from the American College of Cardiology is to have their artery opened within 12 hours.
So for CON purposes, we have primary and secondary, two categories, which we've termed emergent and elective. We've talked at length about how there are three categories. Within elective, there are two categories, the elective and scheduled procedure versus the urgent that you were just describing. The applicants have focused on the urgent. The interveners have focused on the elective scheduled, and we heard back and forth on that. Do you have data on the number of referrals or transfers? And we're going to talk about the difference in those also, but referrals or transfers out by each of those categories. How many are urgent? How many are elective scheduled?
So the number of transfers out for the for these purposes, I'll call them elective outpatients, those stable patients, they're not really transferred typically because the example I gave earlier of Dr. Yekta's patient on the table wouldn't be a transfer, right? They would be sent home if they had their angiogram at Norwalk Hospital. Or they would decide not to have anything at Norwalk Hospital, maybe nothing at all. Or they decide, okay, I'll go to another hospital, have this, who does have the capability of opening the artery in the same sitting. So the transfer issue is completely related to that middle group of patients.
So transfer is urgent and they're inpatient.
Yes.
And do you have the number of that category that's transferred and then what that would be brought in under this?
Yeah, we do. I believe that number is a little over 100 patients a year, 100 to 150 patients a year transferred out, right? Yeah.
This has been Jensen for the applicant. I would just point to our application where we provided that transfer data. I believe it was about 198 patients during 2024 that were transferred out based on a diagnosis associated with the circulatory system. And then separately in our responses to the issue number 1 on the OHS issues list, we provided the CHIME data, Connecticut statewide, showing the breakdown between on a PCI procedure between inpatient and outpatient, showing that statewide it's about 2/3 inpatient versus 1/3 outpatient, 67.9% in 2025, inpatient 32.1% on the outpatient level.
Thank you. Some of this is about getting terminology consistent across all of the different places where the terminology is used. The application uses transfer/referral for certain types of the transition. So I want to make sure that we're all talking about things the same way. So that's helpful. You walked us through how a patient gets to the procedure. Could you describe the follow-up care that happens after that procedure happens? Types of visits, number of visits, types of care, all of that.
Sure. Are you referring to the elective urgent or the elective elective?
If you could distinguish between the treatment, the post-intervention treatment for the two, that'd be great.
Sure. So I'm going to call it the elective urgent. Frankly, is a heart attack. By all criteria, by American College of Cardiology, these people have had damage to their heart. So they're treated. They leave the hospital and they now are aggressively managed for basically typically 2 things, right? One, for the damage that was done to the heart. So medications to try to help the heart muscle recover. They're seen very quickly after the procedure by our outpatient team. They are put on appropriate medications. They're referred to cardiac rehab, and lots of steps are taken to help them with all their risk factors, whether that's hypertension, diabetes, their dietary issues, exercise issues. So all of that is addressed. Every case is individualized. There's no specific protocol, but I can tell you that those patients are seen very quickly after discharge and usually pretty frequently until we've gotten them fully stabilized. Oftentimes, those patients will have the blockage. You know, there's three main arteries, right? So one of them is causing the acute problem. Oftentimes, they're having other arteries that could be an issue. So they will need to go back to the outside hospital again to get those other vessels addressed. So that's also, you know, considered. The patients who are elective, scheduled, tend to get the same type of treatment. Just, you know, the urgency of follow-up and things like that tends to be less. And hopefully we've found them before damage has been done. So that's typically the care that's given post-procedure.
So I just want to clarify, when you refer, if you were under this proposal, you refer to Dr. Yetka. Apologies. It's you as the general cardiologist who's doing the follow-up, not the interventionist.
Good question. I would say the majority of the time I'll be doing the immediate and follow longitudinally will be me. If they need another procedure, they'll see Dr. Yekta. Sometimes there's issues with access, you know, where they put the catheters in the wound, and the patient will see Dr. Yekta because he wants to look at the wound and make sure he's healed properly. So sometimes it's just me in this example, but not always. There are times where he will follow up with Dr. Yekta either for wound issues or because further procedures are necessary.
And under the current circumstances in which you have to refer or transfer, depending on the case, to another hospital, do you have any, can you describe what proportion of patients are doing their follow-up with you versus staying with their interventionist, wherever that may have been? And is there loss to follow up in that transition back and forth?
Interesting question. I say that when it's elective outpatient, unusual that I wouldn't see that patient back. If it's elective urgent with the heart attack scenario, it would not be that they'll stay with the outside doctor because they did a procedure on them and they're concerned about more procedures down the road and they want to maintain that relationship. And as you know, patient choices is paramount. So if they felt that's what they wanted, then we certainly respect that wish. So in the scenario of urgent, elective urgent,
you had said that occasionally a patient can have two arteries that have issues at the same time, correct?
that's true, yes.
Okay, and so if one artery is considered and another artery then would be considered perhaps a left, is it possible for a patient to receive both arteries taken care of in one procedure, or will they always be two?
So that might be a better question for the interventionalist because there's a lot of technical. Defer to that.
So in response to your question, you're absolutely right that both arteries can be addressed at the same time. And I think I brought that example up a little bit earlier. You know, if we had a patient that came in with an emergent artery and had another blockage, I think it's actually becoming more standard that in the same sitting we would fix the other artery. it should be done within 30 days, but in fact, it's probably better for the patient to do it right then and there. But unfortunately for this patient, we had to take everything out, do another procedure during the same hospitalization, just transfer him, extended his hospital course by 2 days, actually, unfortunately.
The application, this is Boyd Jackson. The application describes both a patient who you would have done the second procedure, but determined that it was elective, and so you closed up and transferred, or yes, transferred. It describes another patient that needed to be closed up after the emergent because they needed time to heal before a second. So, you just said it would be standard to do the elective or urgent at the same time. Can you differentiate kind of proportions there as far as, is it standard to do both at the same time? Rare exception that is, needs time to rest between procedures, or how does that break down?
I think a lot of it depends upon patient characteristics. For example, we have a lot of data, indicating that we can use so much contrast on a patient in a certain sitting, or we also use fluoroscopy. We shouldn't use excessive amount of fluoroscopy in one setting. So in most cases, if the patient's not complicated, the procedure went fairly smoothly, we can usually do everything in one sitting, especially if they have normal kidney function. The one time which we consider staging an intervention is if their kidney function isn't completely normal. So then we worry about giving them too much contrast. Contrast can is metabolized by the kidney, so that can affect kidney function. So we give them time to quote unquote wash out, hydrate, things like that. So usually it's patient characteristics for us rather than the ability for us to do that or not.
So just to add on to that, so a patient comes in with that full-blown heart attack, Dr. Yekta opens it up, and then they've got stent blockage in another artery. As Dr. Yekta said, more that artery, that second artery, is being intervened on in the same sitting, or at least prior. So in Norwalk, for that patient who comes in with that blocked artery, they can get that blocked artery opened. The second one that's 90% blocked, it's going to be a transfer, or it's not going to be done. So that's the difference.
And does that show up in the coding, doing a single emergency versus now you've added the secondary artery, which is urgent? Is that getting a different code than the procedure of an emergency PCI?
Yeah, the final hospital sort of DRG coding in that setting, I couldn't speak to with any expertise, but in terms of the billing, it is a percutaneous intervention with what we call additional vessel. So I do imagine that there's some additional coding at the end that would reflect that.
So this is a question that's come up just as a definition of what it's being done is. Questions came up over the last 2 years about this very instance of I'm doing a primary emergency, there's a secondary urgent blockage. I'm not approved for secondary, so I'm not going to do that. I'm going to close up and transfer. But so by doing the secondary artery, that transfers from a primary to a secondary, that makes it disallowed to do.
Well, the overall, the procedure would still be primary PCI for the culprit, what we call the culprit vessel. right? Tagged on to that would be additional vessel. So I'm not sure if that answers the question, but you know, and the question also becomes, okay, let's say we all consider that part of the primary PCI, right? Well, then what about the patient who Dr. Yechter's either given enough contrast or radiation to say, you know what, let's take the patient off the table now, address that negative sitting prior to discharge, right? Okay, does that still fall into the sort of primary? It's a little bit of a
Yeah, thank you. That part was helpful.
So walk me through what happens right now when you have somebody who can do, I actually just want to follow up on, when you can do one of them here, one of the primary at Norwalk, and you have to transfer them for the secondary to Danbury. What does that process look like?
So let's take an example of, so a patient comes in, their acute myocardial infarction is fixed. So then one of two things happens. Either, we have different ways of accessing the heart arteries. We can use the wrist or we can use the leg. Because usually the wrist will take the catheters out, we'll put it on there and let the patient recover. Well, if it's the leg, we have two options. Either we leave a catheter or a sheath, what we call a sheath is basically an entryway into the artery, in the blood vessel, and just kind of sew it in. The reason why is because, again, when we use the leg, there's a slightly higher risk of hematosis and just bleeding and things like that. So why try to entry again? But usually we would close it because, again, we don't want to leave something in the artery if we can avoid it. But then we would call, the a transferring hospital, and I would speak to the interventionalist, and hopefully it depends on where the patient's going. If they're going to an affiliated hospital, then the interventionalist can look at the pictures, and then we can decide as to what their access is going to be. Do we take out the sheath from the leg, and then do they do the procedure over again? Or do I leave the sheath in, obviously with increased risk of infection, increased risk of bleeding? The patient's bed bound at that point, can't move anymore until the patient's done, and hopefully that'll be done the next day or the day after. And the procedure is done. But if the patient goes to another hospital, then it's really by description. This patient needs this done. Can you hopefully fix it? And, as the interventionalist, a picture is worth 1,000 words. It matters a lot as to, what we see, how I'm going to approach a vessel, how I'm going to fix it. So that can be lost in translation sometimes in these transfers. So ultimately, the patient then will be transferred and have their intervention again, usually in not the same day, usually be a second or third day.
So speaking to Danbury, we're talking about intersystem transfers. If a patient is going to Norwalk, does the patient keep their same doctor or surgeon?
Not necessarily. Unfortunately, we can't be in more than one place at the same time. So if I do the case, for example, on a patient on a Monday, there may be a time I can do the same patient on another day if I happen to be in Danbury, but oftentimes that's very hard to manage logistically. So oftentimes it may be a second operator doing the same procedure on the patient. This happens in both for the emergency patients, for the elective patients. I'll do a diagnostic procedure on somebody, and then somebody else will do the intervention if it's quite a Danbury. But sometimes yes, but much of the time, no.
If a patient goes to Danbury, do they repeat the intake process that they did in Norwalk?
Yes. Yeah, basically they don't get discharged. I mean, they get readmitted, they're meeting a whole new crew of people, including hospitalists, nurses, fellows, a general cardiologist attending. So you're talking about a complete transition of care. Nobody really knows that patient. When they get there, the patient doesn't know anybody else when he gets there. So it's unfortunate that there's there's a loss of location, a loss of continuity of care for patients.
Do they repeat the same workups?
They're going to get repeat blood work. They're going to get repeat EKGs. That'll all be done all over again. So that's duplicated.
So imaging and lab testing as well, or?
In terms of imaging, they probably, it depends on the clinical scenario, but generally the imaging wouldn't be duplicated. It may, like a chest X-ray may be duplicated, but lab tests are generally repeated.
In earlier testimony, they had mentioned that transfers are by not the emergency EMS. Would that be used for somebody who, if you were leaving in the leg opening?
Oh yeah. So I guess, yeah, I don't know the exact answer whether we would upgrade it, but I suspect we would. I'll let Peter.
Hi, Peter Cordell. Norwalk EMS would not transfer that patient to Danbury. It would still be scheduling through a transfer company.
And how long, staying on the transfer company, does the transfer company do same day? What is the wait time for a transfer company?
Yeah, that all varies. That's a very good question. It could be a few hours. It could be, we've seen this really across the country. It could be many hours. So that's why there's some uncertainty as previous testimony in terms of what time that procedure will be done and when, because it's totally out of our control depending on the number of calls that company has in the queue to get patients over.
What is the average time? I don't know if this is known, but when you transfer a patient from Norwalk to Danbury, what is the lag time to get that patient from your hospital to Danbury and into their elective PCI there?
Yeah, I couldn't accurately answer that question, but is the question from once in ambulance to Danbury?
I'll take.
Yeah, I would just say I don't have an average time, but I can tell you that I've received many calls about what is taking so long. And there have been patients that we've planned on doing the procedure in Danbury that same day that the call was made to transfer them, but they come up so late that they need to be delayed till the next day. So it is a problem. The other, and again, just to think about the patient, telling the patient, as Dr. Lamitz was mentioning earlier, that we aren't sure when you're going to get picked up. We aren't sure whether this is going to be done today or tomorrow. There's been a lot of patient dissatisfaction on that. So, again, it's just not a great situation when we have to transfer patients and just, we struggle today with the microphones, right? Think about putting a sick patient hooked up to monitors with a sheath in their groin into an ambulance and, not having a little hiccup along the way, or a big hiccup, whether it's, related to the patient's condition or it's related to just the transfer process, which is complicated.
Now, for transfers out of your system, can you walk me through what that would look like?
Yeah, it's pretty similar. I mean, I can't speak to what happens once they arrive, We, for some, for whatever reason, if patient had a preference for another hospital, their a friend or a relative recommended the hospital or something like that, we'd respect it. We then, frankly, to find the right phone number, the right contact person. It's not something we do all the time, so there's some delay there. Then we try to respect their wishes, try to get that person available. Frankly, while we, all work closely, cardiologists are pretty siloed in one place or the other. So we don't know each other that well. We explain the situation. They presumably they'll accept the patient. And then, frankly, as a cardiologist, as the attending physician, it kind of goes into this black box, right? So what happens? There's so much behind the scenes that happens. So there has to be a conversation between the transfer centers. Then they find an accepting physician because the attending cardiologist at the outside hospital is just one piece of the accepting. There has to be an admitting accepting physician. So they got to find that person. Then that person has to talk to either me or what we call the hospitalist or the general doctor who's in charge of the patient's care. I hate to say that. Sometimes there's pushback. Why do they need to come? Things like that. And well, they're having this. And so there could be some clinical disagreements. That's not unheard of, by the way. Finally, let's assume that everything's agreed. They accept the patient. Then it goes now to a deeper level. From a nursing standpoint, there has to be conversations and communications. And then the next level, as we've talked about, is the transfer, the actual company who's going to bring them. So all those pieces have to, and if there's any issue on any one of those things, it stops everything in its track. So then, and meanwhile, the patient's really kind of in the dark and you can't tell anybody what time they'll be there and what time it'll be done because until all those pieces have been settled, there's just going to be a question mark and the patient's waiting and not eating. So eventually that person is put in an ambulance and then taken to the receiving hospital.
When a patient is referred elsewhere for elective PCI, do you have any, where does the patient see follow-up care? Do you know where that happens?
Can you repeat that? I'm sorry.
When a patient is referred elsewhere for elective PCI, where does the patient usually see their follow-up care?
So I would say, if as a referring doctor, if I have a relationship with that patient, almost always they come back to me. But sometimes we meet these patients in the emergency room because they don't know they have heart disease until, they were sitting there and all of a sudden they felt an elephant sitting on their chest. So they go to the emergency room and I may be the physician on call then. So they meet me, we evaluate the patient, we talk to the patient and explain the situation and recommend an urgent PCI. They go to the receiving hospital and then they meet another group of doctors. That patient doesn't always come back to me. And the only way I know that is because it's not unusual for me to then, that person comes back 2 years later to the emergency room with chest pain, and I'm looking at their records and see, oh, I saw him 2 years ago, that sort of thing.
I just want to add another point, if I may, about the transfers. In terms of downstream effects, we're talking about 200 transfers a year for cardiac issues. If the majority of those patients could have stayed at Norwalk Hospital, those EMS providers and ambulances could have been used for other patients that truly need it. And again, we've talked about the wait times for these transfers. EMS is busy. So, it's hard to blame the EMS providers for making a patient wait who's, waiting and waiting, but, is less of a priority for those EMS providers than somebody who, just passed out or had a cardiac arrest out in the community. So there are downstream effects from these transfers.
Follow-up question to that. I do see that on page 20 of the application. They do say 198 patients for diseases of the circulatory system. What are the diseases of what's included in diseases of the circulatory system?
So it could be a few things. A significant portion are the patients that we're talking about. So patients with unstable coronary syndromes. It could be patients with, and these are a much smaller percentage, but patients with another vascular emergency. So something like what we call an aortic dissection, where the main blood vessel in the body has torn. It could be something, again, less of a percentage than the patients we're talking about here, but something like a cardiac arrhythmia, where there's a problem with the electrical system of the heart. There's probably a couple more in there, but so that's a pretty general category.
So if it's a general category, how many of those 198 are we talking about keeping at home under this proposal? Because a large part of the proposal is talking about we're going to save money from the transfers under that 198. That 198 is a general category. So
I'd say about half.
Oh, thank you. You already staff a cardiac cath lab around the clock. Is that correct?
Yes.
So are additional staff required to complete this proposal?
Not immediately. I think that, we currently, as we mentioned, staff 24/7. As the volume grows, we'll need to add additional staff. But right now, we can start the program without adding additional staff.
One of the things the application talks about is Norwalk Hospital's success in the door-to-balloon time for emergency. Is there any concern about increasing the volume and whether that utilizes the procedure room and could hinder the ability to achieve the door-to-balloon times necessary? And can you just talk about how the scheduling works and how you might transition someone out when an emergency arises?
Sure. So, this is something that both physicians in the hospital and hospital administrators are very adept at, which is basically triaging and making sure that the resources are there and that there's a plan B if plan A is not available. So typically, we can get a patient, and from the time we hear about a patient in terms of door-to-balloon time to the time they hit the ER, we know upstream or even in the field from EMS, we know that there's a STEMI coming. So even if there's a patient, an elective patient on the table, the vast majority of the time, we can be finished with that procedure, have a room open for the patient, and get that STEMI on the table without any delay. There are times in every hospital, Danbury included, where we've got patients on the table, could be a 2, 4, 5 minute delay, but again, typically not a significant delay. I have had equipment issues where the room that we're using, the equipment fails. Not in Norwalk Hospital, but that's happened, and it happens all over. And so you get the team and you get them to move and open up the second room, which is what we would do. Again, typically we're able to accommodate the patients that are emergencies. And remember, half these emergencies are happening off hours. So, having an elective patient on the table at that time is not an issue. But, we have protocols in place in terms of when and if we need to give what we call thrombolytic therapy. I mean, honestly, I can't remember the last time we used thrombolytic therapy rather than doing a PCI, because PCI is the preferred treatment. So we've got the plan B, but really haven't had to use it very frequently at all.
So we've been through this before, and I think to Dr. Warshawski's point, we do, obviously plan A, but we've planned for it, plan B, and also even if needed, plan C. So in terms of volume, as I mentioned before, we do have 2 rooms at full staff. We're able to operate both rooms simultaneously. So even if we do have easy enough, we just go to the second room, and for example, if the second room is occupied, then we'll find another place. We have other equipment in the hospital. We have biplane rooms, and so we have 2 additional locations we can take these patients to. So I don't anticipate there being any delay apart from the time it takes the patient to wheel 20 feet more from doing an emergency case. In terms of equipment, we're already fully elective PCI program. It's funny, I go to Danbury and do elective PCI there. The same exact equipment I have in Norwalk. It's literally, it's almost like working in the same laboratory. So from an equipment perspective, there's not going to be any transition really. Everything intact for us to proceed.
I'm gonna switch. You were talking about having the facilities there, so I'm going to switch a little bit. On page 54 of your application, you state that elective PCI will reduce costs to the healthcare system by reducing unnecessary transfers, limiting opportunities for negative outcomes associated with transfers of care, as well as expenses associated with transfers to higher cost institutions. Is your cath lab in Norwalk already essentially functioning and paid for?
Yes.
So that cost has already been absorbed by the system, correct?
Yes.
Okay. So really it's just the transfers that these people are going to save and the costs associated with transfers. Is that correct?
Well, the cost associated with transfers, the reworkup, if you will, in terms of society's cost to providing this care, right? So more lab tests, more time. What does the hospitalist make per hour? What does the nurse make per hour? What else? Patient on the other end, cost. It's that's a real cost to the healthcare system, if you will. And then, again, you've got the human cost, right? Where patients' families got to travel longer. Patients' anxiety, all those things, I think are important to keep in mind.
That's the program you're required to staff a program that you're not allowed to use. We are 24/7, 365 for emergent cases only. So the cost of providing that care to the community is extremely high. And the ability to control, certainly by being able to care for more patients is certain advantage to staff. More staff's actually a good thing. We don't have the on-call burden, as much of an on-call burden. It's a lot of work to maintain a low volume program that you're not allowed to kind of grow into. And that should be really considered when looking at costs, not just of what it costs to transfer somebody, but the cost of running a program that you're not allowed to use.
Did you have anything or no? All right. How,
Cost. Again, because we got to sort of reinvent the wheel when the patient gets to the next hospital. And typically the patient's not going to get done the same day. It's enough to stay in the hospital. So they typically is higher.
do you know how much longer stay would
I would say a day longer.
day longer? Okay. No problem.
I think if you look at our response to completeness question number 4, in there you will see what we've quantified at Danbury Hospital, the cost difference. Where for a non-STEMI patient transferred to Danbury Hospital, the total cost of care for a transferred patient was $41,009 versus $27,500 for patients presenting directly to Danbury Hospital. And then specifically for non-STEMI transferred to Danbury who received a cardiac catheterization, but noted the transfer average was $22,437 versus $13,902 for patients presenting directly to Danbury Hospital.
So what do you expect the cost to be for people once, if you were granted elective PCI, would they be?
It would be more like the 27 and the 13, but at Norwalk, not Danbury, relative rates.
Okay. I just have one more. So it's about the retention approach used in Exhibit A on page 18. The market share approach and the transfer retention approach. I have a question about scenario 2 and why you chose to use all hospitals. Sure, yeah, take your time. It's base page 18.
I think there's 2 components to your question. The first is when you look at the transfer data, it is largely bucketed because one, you don't know what the final code is going to be, and you are not final coding before a transfer goes out. So it is that bigger bucket.
The statewide healthcare facilities and services plan cites research that elective PCI is a service that is prone to overutilization. Can you speak to the protocols that have been mentioned several times for ensuring proper patient selection?
I'll take this one, thanks. So we actually monitor how many of patients are, how many of our PC are what we call the elective outpatients, where the tends to be the risk of being overutilized. Again, because you can manage the majority of those patients with medical therapy. So within Nuvance, we actually track, which is somewhat unusual, I would say, but we track the proportion of inpatients getting PCI to outpatients getting PCI. And again, those truly outpatients are the minority of our PCI patients. So there's somewhere between 30 to 40% of our total PCI numbers, which compares very favorably in terms of being reassured that we're not overutilizing PCI in that population. The other thing that we track very carefully, and we are part of the national registry for PCI, both in, across all of our hospitals that do PCI. We're part of the national registry. We actually have our own registry team that, as opposed to a lot of other systems that farm this out to outside companies, we have our own on-site folks abstract charts in terms of who's the patient, why did they get the PCI, and that is looked at in total, not just for outcomes data, but for appropriate use criteria. So when you look at our appropriate use, meaning patient was on the appropriate medical therapy and still having chest pain and had a high-risk stress test, that patient would certainly be appropriate for an outpatient PCI. If a patient is on no medication, has a blockage, they're able to do a fair amount of exercise, that patient theoretically would be an inappropriate PCI. Our inappropriate PCIs are essentially zero across our system, and we would continue to monitor that, of course. In terms of Norwalk Hospital now specifically, and across our system, are the inpatients, those who present with unstable coronary syndromes. Those patients are, I would say, almost always appropriate for PCI, because again, that's where the mortality benefit.
And for the elective outpatient, is that a procedure that's generally subject to prior authorization, utilization review, other type of Medicare contractor oversight?
Yes.
And okay, all of the above?
All of the above.
Thank you.
Great, thank you. I'm gonna go ahead and move to the intervener. I'm gonna ask them questions. So my first question for the intervener, if you want to go ahead and bring down your witnesses again. The applicant, if your witnesses need to take a quick break, they can do that. We may have a few follow-up questions, but they can, they've been sitting for a while, so.
Good afternoon. My name is Karen Gottlieb, and I think I'm on the list, but I don't know if it's my
No
time.
problem. All right, Attorney DeBasio. First question can be answered by either one. I would just recommend that you state your name at the beginning of answering questions, so that we can keep a clear record. First question is, does Norwalk Hospital, or sorry, does Stanford Hospital receive elective PCIs from Norwalk?
So Scott Martin. So we checked to see how many transfers we got, for the urgent electives, and it was 3 since we changed medical record systems like 9 months ago. So it's rare. We get patients generally only if they request us, like if they're already following with our group.
Okay.
Those are the inpatient transfers we get.
How many non-urgent, like somebody who could walk in and schedule and come in on that day?
So I can't recall having anybody who had a diagnostic cath at Norwalk Hospital then coming for a PCI with me at Stanford Hospital. I do roughly half of our PCIs. So if it was a commonplace occurrence, I would know.
All right. How many elective PCIs do you get from people who live in Norwalk?
That I don't know.
If somebody were to so you said you've had 3 in the last 9 months. What would the transfer process look like into your hospital?
Yeah. So I think the what was stated is pretty well accurate. There's a hotline, so one number to call to start the transfer process, but then it requires going sort of a hospitalist to hospitalist exchange. And then there's some administrator involved in accepting them and making sure there's a bed available. And probably something to do with insurance at that point as well. And then the ambulance transport is arranged from their end, I believe.
Okay. You would then repeat the intake, is that correct?
There would be portions of the intake that would be repeated, but in general, we have a process where we request all of the clinical information on the patient. That includes any type of imaging, any type of lab work, any type of other relevant clinical workup that was done on the patient. And that would be transferred with the patient. Usually a W-10 is filled out that includes all of the additional clinical information that the providers would need. So tests are not replicated if they're available and able to be sent at the time of transfer. And usually that information is obtained at the time in which the transfer is being arranged, or it's sent with the patient at the time that the patient's transferred via ambulance. So in general, things are only repeated if clinically necessary or unavailable.
Okay. And approximately how often? Oh, I'm sorry. State your names.
Liz Longmore.
Thank you. And how often are you provided with all that information at the time of transfer?
So I would say the vast majority of the time, blood work and such is included. Typically, if they're sent after a diagnostic catheterization, they're also sent along with a CD of the imaging, so we actually can see the images. So that's doesn't have to be replicated. So I would say the day of transfer, the replication of testing and such is rare, minimal.
What is the cost of elective PCI at Stanford?
We just need a moment to check to
Nope.
see if we have that
Take your time.
immediately available.
Yeah, I don't think we have the answer to that immediately available.
Yes, Hearing Officer Novi, I don't believe that was part of either of these two individuals' pre-filed testimony. So if it's something that OHS would want, there's no objection from the applicant. We can certainly provide it to OHS.
If you could provide that, we can make that a late file.
Absolutely.
Also, yeah. You could go ahead and follow up with that data in a late file, or in that file, you could cite, point us to, if you're using our data, where that would be as well. I think and then, sorry, I have one last question. What would the average wait time to receive an elective PCI at Stanford be?
We have same day availability.
Okay.
This is not a question for you. It's a question for Attorney Jensen. It's related to the late file that was just requested multiple times. The applicant cited that they were lower cost than Stanford Hospital for this procedure. And I believe they referenced that it was cited in the application. Are you able to direct us to that, or could you provide the basis for that in a late file? And if you want to reply after our break, that's fine.
Thank you, Ben Jensen. Yeah, I think it'll be helpful if I could reply after the break. I would say the question was about this procedure. We don't perform this procedure, so we don't have the ability to provide costs for it. So I'll look at what we did submit in that application, how we got to that.
All right, so we'll take 15 minutes. You can clarify after this, and we'll decide whether we need a late file. If we have any last follow-up questions, we'll ask those at that time. And then we'll proceed immediately to closing statements.
Thank you.
So we will go off the record and come back at 2:55. All right. We'll start by clarifying the late file request, and we're going to ask for this of both the applicant and the limited intervener. If you look at tables, OHS Table 3 and OHS Table 4, it asks for the average cost per self-patient pay and the average cost per commercially insured patient. Procedures that fall under the category. We're going to ask that you complete tables 3 and 4 for each of the 3 types of procedure. So inpatient, primary PCI, inpatient, secondary PCI, and outpatient, secondary PCI. to provide tables 3 and table 4 in the application, the average cost per primary patient, secondary outpatient. That's the projection for whether that's relying on the historical, which would be the actual 24. And we'll have an order on the pre-file tomorrow.
Okay, with that, we will follow up with the app. Follow up with the applicant on questions posed by OHS to the applicant. Do you have any additional questions you'd like to follow on?
I don't. Was there still an intention to circle back to the request of the
If you can refer to where it is in the record, that's helpful, but I do think that it's covered by the late file request.
Okay, then I will leave it at that.
Great, thank you.
Okay, Attorney DeBasio, do you have any follow-up by the intervener and questions posed to the intervener? All right.
No, thank you, Madam Hearing Officer.
Thank you. All right, so with that, let's get to the late file. What are you guys looking at for how long do you think it's going to take for you both to get those together? Yeah, take your time. And set realistic goals for everybody. So yeah. Why don't we? Oh, no, let's give them to the end of the week. We'll do the end of the week. So usually, November 21st, which is PM, if you can file on that date, I would, or by 5 PM on that date, would appreciate that. If you need extra time, as always, you can let us know, reach out. We will set a new date. Sorry, I'm just making a note for myself. My handwriting is horrible. At this point, we do have the person who wanted to make public comment earlier, who was not available, is now logged on and would like to make public comment. I'm going to let them do that before we go to closing arguments.
Okay, I guess that's me. Good afternoon. Can you hear me?
Yes, this is Karen Gottlieb.
Yes, good afternoon. My name is Karen Gottlieb, and I am here to express my strong support for Norwalk Hospital's proposal to expand cardiovascular services by offering elective percutaneous coronary intervention to residents of Norwalk. As the executive director of the AmeriCare's free clinics, I advocate for low-income uninsured residents of our region. For our patients, missing work for medical visits or hospitalization can have devastating consequences. Bringing elective PCI closer to home is not a convenience. It's a matter of equity, safety, and survival. Being close to family offers comfort and lessens the financial burden associated with travel on congested highways to other hospitals. Heart disease remains a leading cause of death in Connecticut. In a state that claims to prioritize health equity, I am deeply concerned that previous applications have been denied. Norwalk Hospital already provides emergency PCI and has the infrastructure, surgeons, and staff to safely perform elective PCI. Yet patients, some of whom need this procedure within 24 to 48 hours, are forced to travel outside their community, often under stress and at increased risk. This current system drives up costs through unnecessary transfers and repeated diagnostics. It delays care. It undermines equity. And it creates a harmful divide between those who can access timely cardiac care and those who cannot. Norwalk Hospital has world-class capabilities. Denying them the ability to use those resources for elective PCI is not just inefficient, it's unjust. I am encouraged by the Office of Health Strategy's updated guidelines, but now we must act. Approving this application is a critical step towards leveling the playing field and ensuring all residents of Greater Norwalk, regardless of income, race, or zip code, have access to the contemporary standard of cardiac care. This decision matters. It matters to me and it matters to the patients we serve. I urge you to approve this application. And I'm going to go off script for 1 second here and just say, if I were a patient in the cath lab and having had a heart attack and an intervention and had another blood vessel that needed to be taken care of and was told I was going to be discharged to another hospital and get it done in a day or two, I would be scared to death. I think the stress for the patient is something we should be looking at. Thank you very much.
Thank you.
All right. At this time, I'm going to open to closing statements. We are going to start with statement from the intervener's attorney. I don't know if you guys want to share the mic or you want me to come bring you one.
Thank you, Hearing Officer Novi. And on behalf of myself and my client, Stanford Health, I would like to thank you for the opportunity to participate in this hearing. OHS has been presented with testimony exhibits and public comment, all related to this application. And while admittedly the guidelines may have changed, and there may have been advances in medicine and treatment since the applicant's last CON application for elective PCI services, the language of the applicable statute has not changed. Ultimately, it's the legislature's prerogative to amend the statutory language or not. And today, it is the applicant's burden, it's the applicant's responsibility and obligation to meet its burden of establishing that the present application should be granted in light of the statutory language. And it is ultimately up to you, Hearing Officer Novi, to determine if Norwalk's application for a CON does or does not satisfy the statutory requirements. And to be clear, Stanford is not claiming that physicians and staff at Norwalk are unqualified, nor does the application claim that the 4 area hospitals that currently provide elective PCI services are unqualified. The application also does not claim that the 4 area hospitals are overburdened or incapable of meeting the demand for elective PCI procedures. Norwalk goes to great lengths to talk about patient choice and convenience of services. However, the application is for a certificate of need, not a certificate of convenience. And again, it is the legislature's prerogative, if it chooses to amend that statutory language to make convenience a part of this analysis. Norwalk also goes to great lengths to refer to the application as an expansion of its existing capabilities. However, when one looks at the underlying data, it is clear that this expansion comes at the expense of existing services currently being provided by other area hospitals. The data establishes that the demand for elective PCI is not anticipated to grow substantially in the upcoming years. The data establishes that there is a shortage of skilled professionals in the area that can provide elective PCI services. Just today, Norwalk admitted that if this application is granted, they will have to hire and expand their staff in order to provide those services. The data establishes that patients in the service area that need elective PCI services have been able to receive those services at the 4 area hospitals that are licensed to provide elective PCI services. It is respectfully submitted that if the application is granted, its impact on the utilization of elective PCI services would negatively impact the overall healthcare system, and that there would be a lack of skilled professionals to fill all of the jobs available, and the demand is not significant enough to support 5 area hospitals. And in closing, as existing services, and of the citizens and the population of the proposed service area that is not currently being met. Those criteria are specifically referenced in the applicable statute, and the evidence and data the applicant has provided you is not sufficient for the granting of the con. Thank you.
And we will go to closing statement from the applicant's attorney, Attorney Jensen.
Thank you, Hearing Officer Novi, OHS staff. I appreciate all the time today. I started out today by emphasizing that Norwalk Hospital is not here asking to establish a new facility or a new service. Excuse me. It has been performing emergency PCI procedures since 2009. In that time, the standard of care and technology has evolved such that this procedure is safer than ever, and much of the concern about performing non-emergency PCIs without having cardiac surgery on site as a backup is no longer relevant. Connecticut has recognized this evolution and updated its statewide plan accordingly. I quote, "Increasing operator experience, improvements in surgical technique, and major advances in technology and pharmacology have contributed to a progressive trend to allow PCI without on-site surgical backup." At the same time, the Joint Commission, in collaboration with the American Heart Association, updated its eligibility requirements to remove volume criteria from their certifications to allow more cardiac centers to provide these procedures to patients who need care, expanding access to patients where they live. So the question before OHS today is a different one. Respectfully, I disagree with counsel who said that the statutory language remains the same. The statewide plan makes clear that this is a new standard that we are looking at specific to the issue of on-site, of PCI on an elective basis without surgical backup on site. And based on the statewide plan, there are two issues for OHS to consider. First, has the applicant committed to following updated SCAI guidelines for staffing, equipment and supplies, patient and case selection criteria, transfer agreements, and other quality standards? Second, is there a clear public need for the program that tracks with the statutory criteria under 19A 639? First point, yes, Norwalk Hospital's application demonstrates that it has adopted policies and will follow the SDI guidelines, including the PCI treatment algorithm for case selection. This gets to the concern about overuse that I know was raised, overutilization of the procedure. Norwalk has already put in place those procedures and is committed to following those guidelines, and then it's going to monitor and then it transparently reports on its use of this procedure. The physicians today here have emphasized the importance of continuity of care and the fact that PCI procedures are merely one step in their clinical decision-making and treatment of patients. This is the contemporary standard of care, which Norwalk Hospital is fully capable of performing. And notably, even the witnesses of Stanford Health who oppose this application have readily acknowledged that they do not dispute that the physicians at Norwalk Hospital are fully capable of safely performing these services. But instead of following this contemporary standard of care, Norwalk Hospital is forced to send away its patients. And at that point, we lose control over the treatment of the patient. Disjointed care, repeat procedures, transfer challenges, systems that don't speak to each other, closing up patients that are already receiving an angioplasty unnecessarily when there's another artery with a significant blockage. The physicians have discussed all of this today, and I dispute the characterization of this as anecdotal. This is their living experience every day treating these patients at Norwalk Hospital. Second point, is there a clear public need for this program? You heard the public comment today. Norwalk is a city of almost 100,000 people. It is the sixth largest city in the state of Connecticut. It is a majority non-white city, and 28% of the population is foreign-born. There is currently no facility in the city of Norwalk that is authorized to perform PCI procedures for patients who are not acute enough to qualify for a PAMI, for a primary PCI on an emergency basis. The application discloses nearly 200 transfers in 2024 alone out of Norwalk Hospital with a primary diagnosis related to the circulatory system. These are patients in the community who are choosing care at Norwalk Hospital but are being forced to travel elsewhere, despite the fact that Norwalk Hospital would be able to perform this very procedure, a PCI, if only their symptoms were more acute. Now, as the witnesses have testified today, the fact that these are not emergency cases does not mean that these patients are not in urgent need of care. NSTEMI patients are having a heart attack. While there are some patients that are truly elective and can be scheduled on a non-urgent basis, the CHIME data cited by Norwalk Hospital shows that approximately 2/3 of the PCI procedures on a statewide basis are performed inpatient, meaning that on a more emergent basis, emergent or urgent, as opposed to elective. Now, because of these volume requirements that were in effect before, for too long, cardiac care has been a case of the haves and the have-nots. Community hospitals without surgical backup on site were denied authorization to perform procedures they clearly were qualified to perform. And there are downstream impacts of that to the reputation of the facility and its providers and the trust between those providers and their patients. Conversely, the haves, Stanford Hospital, objects to this application, not based on safety concerns, not based on any concerns about the patient, but rather on the impact to its bottom line. More importantly, patients have been denied the choice to receive necessary care in the community and forced to incur disjointed care and delays associated with transfers to other facilities. But OHS has an opportunity to correct that situation today. This is a win-win. There are no added costs to Norwalk Hospital or to the state healthcare system to be able to perform these services tomorrow. Norwalk Hospital has a cath lab and a team that is already equipped and staffed and competent to safely perform these procedures and to handle additional volume. It has the advantage of its affiliation with Northwell and its extension model focused on building up community hospitals, keeping care local, and aiding in recruitment efforts based on what Dr. Singh discussed today about all the different ways that they are driving recruitment efforts. Patients will have a choice to stay in their community for their care. The quality of care will be improved. Access for minority and underserved patients, including ones on Medicaid, is improved, and costs are lowered. We trust Hearing Officer Novi that as you review the evidence and consider the criteria under Section 19A 639 and the statewide plan, you will conclude that allowing the residents of Norwalk and the surrounding communities to receive the advanced cardiac care they deserve at the facility that they trust merits the granting of this application. Thank you again for your consideration of this application and the time you've allowed us today.
All right, thank you both. I would like to thank everybody who attended this hearing in person and virtually today. It is now 3:14 p.m. and this hearing is now adjourned, but the record will remain open until closed by OHS at a later date. Thank you and have a nice day, everyone.